Now we move on to something quick and easy, the normal pressures of the heart. Now how do we measure to see if the pressures are normal to begin with? Well, we insert a Swan-Ganz catheter through the systemic veins to pass through the right atrium, through the right ventricle, and eventually wedge it into a tiny little capillary of the pulmonary artery. So when the catheter tip wedges into a vessel, it completely blocks the flow. This obstruction of flow can allow us to measure the pressure behind and in front of the catheter balloon tip. So now let's actually discuss the pressures. This is the image from your book. Let's begin with pulmonary capillary wedge pressure. Remember, we just wedged the tip of the Swan-Ganz catheter in a pulmonary capillary of the artery. So the expected range of the pulmonary capillary wedge pressure should be below 12. It directly reflects the pressure of the left atrium because the pulmonary artery capillaries are considered a continuous vessel with the pulmonary vein. So the pulmonary vein drains into the left atrium, so this is a great way for us to measure pressure in it, right? Now in a situation such as mitral stenosis, there's going to be a buildup of pressure in the left atrium. So the pressure is going to be high. And this is going to be because the stenotic valve does not allow sufficient emptying of the left atrium and diastole. So this is a condition in which you would see increased pulmonary capillary wedge pressure or increased left atrial pressure because of the backup of pressure. Now let's discuss the pulmonary artery. The pulmonary artery systolic pressure should be the same as the right ventricular systolic pressure because when the right ventricle is pumping blood into the pulmonary artery, the pressure should be the same. Now the diastolic pressure in the pulmonary artery is higher than the right ventricle by 5 because of the pulmonic valve trapping blood in the vasculature as it closes. So on your step 1 exam, you might be given a vignette that includes pressure readings. For example, if the pulmonary artery pressure in systole is 40, they're going to be trying to give you a hint that the patient is suffering from pulmonary artery hypertension. Now what about the right atrium? The right atrium reflects central venous pressure, or jugular venous pressure. This is because there are no valves between the systemic veins in the right atrium. The diastolic pressure in the right atrium usually equals that of the right ventricle. So 5 and 5, right? The diastolic pressure is the same because when the tricuspid valve is open, it's just one continuous chamber because the valve is not there to separate the two when it's open. This concept allows us to understand why the systolic pressure reading of the left ventricle is the same as the aorta. When the left ventricle is pumping, the aortic valve is open, and the pressure is the same in the two. Now, one important thing here is the diastolic pressure. Notice how the diastolic pressure in the left ventricle is very low, compared to 90 in the aorta. This is because there has to be a pressure gradient in order for blood to flow from the left atrium, which is pressure should be a little bit higher at 12 compared to the diastolic pressure of the left ventricle. This has to be the situation so that when the mitral valve opens, there's a gradient for blood flow. Autoregulation is the ability of an organ to maintain a constant blood flow despite changes in perfusion pressure. This occurs in the absence of any neural or hormonal influences because it's the organ's intrinsic ability to get the job done by itself. This means that local mechanisms or metabolites will usually mediate what happens in autoregulation. One exception is the skin, which is very dependent on the sympathetic nervous system. It has very little autoregulation. It is mostly under control by alpha-1 mediated vasoconstriction. This is how we increase systemic vascular resistance and also shunt blood away from the skin. Now the heart uses products of cell respiration, which is an increase in carbon dioxide or an increase in adenosine to modulate coronary vascular tone. For example, if the heart is beating much faster and harder, the myocytes mitochondria will be working hard to make more ATP. Eventually, we're not going to have enough ATP, and now we start accumulating the precursors of ATP, which are ADP and AMP. So the precursors will then be broken down into what? Adenosine. So why do we want to do that? Well, we've used up all of our ATP because we've been using high amounts of cellular respiration. The heart already is extracting 80% of oxygen from the blood. So what we need to do is to increase the supply of blood to the myocardium. Adenosine is going to vasodilatate for us. And it's going to open up those vessels so we get more flow. Now let's look at this image. Another important local mediator is nitric oxide. It is the most important vasodilatator basically that we know about. Someone will definitely ask you about the biochemistry, so we should review that quickly. Important things to always remember: it is made by the oxidation of L-arginine by nitric oxide synthase. This is within the endothelial cells. This will also diffuse over to the smooth muscle cells that are very close by, and it's going to induce soluble guanylyl cyclase. It makes tons of cyclic GMP. Now, this cyclic GMP is going to cause vascular smooth muscle cell relaxation. In the end, it makes our vessels dilate. You have to know this because one of the most used drugs in the world works by preventing the breakdown. Remember which enzyme sildenafil, aka Viagra, is going to inhibit to keep cyclic GMP high. Well, all the drugs that end diesterase 5 inhibitors. So this has the same end result of smooth muscle relaxation and increased blood flow to the corpora cavernosa because it inhibits the breakdown of cyclic GMP. Because here's an important image again: the corpora cavernosa of the urethra and the corpora cavernosa of the penis are going to be maximally dilated. Receptors and their ability to indirectly sense carbon dioxide levels by the proton concentration. This is more important than how local metabolites regulate cerebral blood flow. This kidney has a unique and highly testable mechanism of autoregulation. First of all, there's a myogenic, which responds to the amount of stretch of the afferent arteriole to regulate vascular smooth muscle contraction. Now, the tubuloglomerular feedback similarly regulates afferent vascular tone, but it refers to the communication of the salt-sensing cells of the macula densa, and they do this by communicating with the juxtaglomerular cells that are right there also next to the afferent arteriole. This is for a reason. The macula densa communicates with the juxtaglomerular apparatus to control the release of vasodilatory factors such as prostaglandin E2 and prostacyclin. So this is why NSAIDs are so bad when you're talking about blood flow to the kidney. They inhibit cyclooxygenase, and therefore they decrease the production of these vasodilatory agents. So now we get vasoconstriction of the afferent arteriole, and that decreases the blood pressure or perfusion pressure to the kidney. All right, now what about the lungs? How are they unique? Well, when there's low oxygen, this is the only organ that actually vasoconstricts when there's low oxygen tension, right? This is because we want to redirect blood flow to the more oxygenated alveoli. We want to prevent physiologic shunting. We don't want to waste perfusion. We have to make sure we vasoconstrict to shunt away from areas that aren't delivering enough oxygen to the alveoli. Here we go. By what mechanism does increasing heart size increase myocardial oxygen demand? By causing an increase in wall tension. Remember the law of Laplace here. It pops up again. If we increase the heart size by either increasing the thickness of the myocardial wall or increasing the radius of the chamber, there's going to be an increase in the wall tension. All right, now we hit capillary fluid exchange. Fluid transfer across capillaries is an important equation to know by memory and also conceptually, because so many diseases can disrupt the balance of these starling forces. Examiners absolutely love this equation because it tests your understanding of the physiology behind fluid shifts that actually happen in patients all the time. So let's talk about the components of this equation. First of all, this JV is the net fluid flow. Hydrostatic pressure is always going to be denoted by P, so there's a PC and a PI. The hydrostatic pressure is the difference in the fluid pressure between capillary lumen and the interstitium, which is represented by I. So remember, the P with a small c represents the gradient of pressure from the capillary space to the interstitium, and the P with a small I represents the gradient from the interstitium back into the capillary. Now, osmotic pressure has a similar notation, except instead of a P, we use the symbol pi. The pi with a C represents the osmotic pull back into the capillary lumen from the interstitium. This gradient is determined by the negatively charged plasma proteins that are unable to leave the vasculature. The plasma colloid oncotic pressure that we're talking about can actually be lost if the patient somehow is losing proteins in the urine in the situation such as nephrotic syndrome, or if it's just not producing them in the case such as liver failure. Okay, so the pi with a small I here is due to the ability of the negatively charged proteoglycans in the interstitium to actually endothelial cells that line the capillary vessel are the fluid and protein respectively. You can only change this by altering the junctions. So here are two endothelial cells with junctions in between them. So things such as toxins, cytokines, infections, particularly histamine is high yield here, can actually change the junctions between these cells that line the capillary vessel wall. Burns are unique in the fact that we just completely obliterate these vessels. Everything is destroyed. Now let's get a little more in depth and understand why these arrows are pointing to certain ways along the capillary vessel. Do you see how the capillary hydrostatic pressure is flowing out of the capillary on the arterial end, and now it's flowing in on the venular end? This is because resistance is very low, and the fluid that was just pushed across the capillary wall on this side can now come back in on the venular side. So this hydrostatic pressure gradient influences oncotic pressure directly. For example, on this arterial end, indicating that her heart was beating really fast. She had a syncopal episode and passed out. So, well, what's going on? She's obviously had this before, so something has continued to happen. There has to be some underlying problem, right? So she's a little bit hypertensive, 130/90. That's kind of high for a young kid. And her heart rate's pretty good, 85. The real clues are in the description of the electrocardiogram. Zone in here, you have to know these. So for some reason, there's this slurring of the initial parts of the QRS complexes, short PR intervals. What are they talking about? They're talking about WPW, right? This is how board examiners are going to test you. They are describing these delta waves when they're talking about slurring of the initial parts of the QRS complexes. They're not going to say a delta wave. They're going to describe how the ECG looks. Try to avoid buzzwords such as delta wave. Remember that in Wolff-Parkinson-White, there is an accessory pathway in which the electrical impulse can travel from the atria and ventricles that bypasses the delay of the AV node. This early conduction slurs the initial part of the QRS complex that's seen as the delta wave. This AV node bypass also leads to a decrease of the PR interval. So knowing this, we know the answer is B, atrioventricular bypass tract. Notice how there was no mention of a bundle of Kent or Wolff-Parkinson-White. You have to know the disease from a way that you can describe it to someone. Alright guys, great job. Hope you do great on your Step 1 exam. Good luck.